my journey in United States started 10 years ago, joining Harborview and meeting with Jens in the orthopedic department. He kindly get me into appointment in the orthopedic department as well as the anesthesia that we start talking about spine care. And I remember our first QI meeting that there was a patient we were discussing, and I don't know whether you remember, Jens. Patient we were discussing, and I found out patients died in the hospital before discharge. And as we were discussing the patient, I reminded that this patient is dead, and it opened up a new sort of understanding that multidisciplinary approach to care of a patient will bring some benefits when we talk about how we can optimize, how we can increase the care delivery and improve outcomes. So my talk has two parts. I'm going to give you a brief update on the SCOAP development, and then I'm going to talk about the PERMS program that we developed in Harborview. So I'm the new medical director for the spine SCOAP. We set up a meeting for the spine SCOAP committee in September 7th to revise the SCOAP program, because program needed some clarity and improved in the data quality. So we sit down and established this team of people. First of all, before going into setting up the program, we had to understand the consensus around the state. So me and Dr. Peter Dunbar, who's the CEO for the foundation, went around to hospitals. I met with Rod then, and we talked about the importance of spine SCOAP, and all the other hospitals also agreed that spine SCOAP should continue to exist. So that was a big commitment. And then we talked about focus of SCOAP. And then we said quality improvement should be the key, and it should be value conscious. And we need to look at the metrics, we need to look at the definitions, and we need to do a revision to make more clear collection. And then there were some requests about engaging the surgeons to use the data to change their practice. And governance condition participation. So this is a big move. Spine SCOAP has been under the SCOAP initiative as a sub program. And what we decided, we will take spine SCOAP to have its own entity under the FHCQ organizational clinical structure. So now spine SCOAP stands alone. It has its own team of members, and that members comes from different, equally representing the state distribution, and have multidisciplinary team. So our activity coming up, sort of, we are focused on case reviews, we're auditing, we always did audit, but we're going to be more careful about how the data coming to the spine SCOAP from the sites to make sure that everybody reporting the same metrics in the same quality. We're going to do inter-rated reliability testing, and then metrics review, and then we're going to encourage this data to be used. And if anything we can do to help this data to be useful for hospitals, we like to engage in discussion to do so. So swiftly moving, I've got only 20 minutes, to our program. I like this slide because it talks about change, and if you don't comply with change, something nasty happens. You know what happens to dinosaurs. So our talk going to talk about the transformation of care at the University of Washington and Harborview Medical Center, and clinic pathway implementation strategies, and evaluate the EPOC spine program. ERAS is the basis of EPOC program. EPOC stands for Enhanced Perioperative Care. And as you know, it started in 1997 with this gentleman, Henrik Kallett, is a general surgeon, And he put together a couple of care bundles to say, if you do this for every patient, colorectal patient, they're going to do well. And they proved that. It was, 20 years ago. 10 years ago, this program find traction in UK and become a national healthcare improvement program. So now, about 4 or 5 years ago, we start to sort of get engaged into this, ERAS initiatives, and now I think US making a huge contribution to the future of ERAS, and ERAS is becoming also more expanded. It used to be just 5, 6 items. Now there are about 20 items of care bundles, and it requires preoperative, intraoperative, and postoperative care management decisions. And it is based on marginal gains approach. None of the individual items by themselves is effective unless they execute it as a care bundle. So, giving nutrition by itself is not effective to show change in outcome. But if you do that with all the other things together, you will get benefit. That requires teams. There's about 65 different groups of people that contributed to this project. And as I said, we moved from decision for surgery all the way to the return to function to look at the care continuum. And then we developed the plan, do, study, act cycles, and we created this team of people. We call them performance improvement team to work on this. And I think many centers are doing this now, probably you guys are doing. We haven't had a chance to talk about this individually, but we wanted to establish change in behavior, and we like to set up the teaming approach for care delivery and develop consensus guidelines and measure adherence to the program and also look at the data. We developed protocol. Jens was there, that we were thinking about this, and established some pre-op, intra-op, and post-operative metrics to be executed for these patients. And it wasn't just ERAS, as I said, it was many other things to make patients satisfied. These include like patient-friendly care maps. We have now electronic applications. We give it to patients to follow them around the hospital as well as their home. They get to be informed that they need to take their medication night before the surgery. So these sort of improvements are making a huge difference on patients' compliance and satisfaction. There were patient health questionnaires executed from the different clinics, like surgery clinics had 6-page document, and pre-anesthesia clinic had a page document, and medicine operative consult clinic had another 2 pages of document. So we sat down and we said, that is not good. Patients filling the same information time and time again. So we developed a single preoperative assessment form in 3 pages that satisfies everybody. By working and changing how we deliver the care in the pre-op area from multiple clinics, we changed the time patient spends in the hospital from 7 hours to 2 hours, 50 minutes in clinic visits before the surgery. We changed the electronic order sets, and we created a multi-phase order set. So everybody in their care locations, if you're on the floor or ICU, can see what the other team's done in their care locations. So that was important because floors didn't know what happened in ICU. So this enabled them to follow them up. We want to do carbohydrate loading because we know carbohydrate loading and proper nutrition increases the insulin sensitivity, and it helps with the recovery. So this is an important concept, although it doesn't come for the spine-related studies, mostly colorectal. I think major spine population benefits this because if you think about it, night before they are stop eating, they get surgery for 6-8 hours. And before they can take orally, it's almost 24 hours. And that is a semi-starvation that should be avoided. So this carbohydrate loads help with the sensitivity. We changed the NPO algorithm, so we are now doing proper preoperative nutrition support rather than nil by mouth sort of program. We encourage them to drink up till 2 hours prior to arrival to hospital. So that is really a big change. It improves the satisfaction too. We announced them all over the hospital on the whiteboards. You see this epoch spine on the note section. Everybody sees this before patient comes to have the surgery, so we know, ICU knows this is an EPOC patient, recovery knows this is an EPOC patient, so they deliver the care that needs to be delivered for these patients. And then we measure some metrics, outcome, process, and balancing measures. Now I'm going to give you those metrics. This became a study, the QI project, and we are publishing it now. So from that publication, it is sort of on review process right now. So the population we're talking about, this major complex spine surgery population, is 4 level and above, more than 6-hour surgery, more than 1 liter blood loss, so anteroposterior surgeries, corpectomies, medically complex patients with improper sort of preoperative optimization, and complex pain patients like pacemakers, buprenorphine use. So these are the inclusion criteria for an adult population. And when we look at the average DRG weights and case mix indexes, this patient scored between, so these are the EPOC spine patients, the dark green ones. They were near 5.5 to 6. So they are hugely complex patients coming in. And the light greens are the other biggish population that is not in the pathway care. And this is the average DRG weight for Harborview. We got, 2.3 in 2016. So you can see how complex our patients are. One of the things we have done as a part of the QI project, we looked at the corrected crystalloid use per blood loss. And we want to establish whether there's a variation on use of crystalloids and volume resuscitation for these patients. And we found scattered everywhere. So that leads us to using goal-directed fluid management. Again, another representation of that argument, you can see in 2015, start to stop fluid use was wide range. And then when we start doing goal-directed fluid management with cardiac output monitors, we reduced the range, although amount of fluid administration increased a bit intraoperatively, but that resulted in better outcomes. And this is the common, you can look at the literature and it is always the same argument. You're giving a bit more, but the timing of fluid administration is the key rather than how much you give. So that is where I think, lacking if you just leave it to the clinician's decision to make that judgment. I will do it postoperatively, or we will take the fluid off postoperatively. So you need to do the right time, right fluid management. And then here we are, our hospital length of stay. We dropped the length of stay from 8.2 days to 6.1 days as a result of this program. And you can see the dates there. It was first month of the 2012 to last month of 2013. And then after a period of implementation, we reported our results from 14 to 16. And again, it was nice to see this reduction in variation. Outliers are come down, and we managed to create some reduction in length of stay. And this is over the years how the length of stay changed. Some people sort of argue, it may be because everything else is changing. It is true. As we said, this is a marginal gain approach. Everything needs to be done together. And if you're creating emotion and creating an agreement among the multidisciplinary teams, you achieve this sort of success as a long, ongoing progress. And again, ICU length of stay dropped significantly too, because ICUs were able to discharge patients effectively there. We did optimization prior to surgery, so their patients were coming much more healthier state. So they were not needing ICU accommodation for that long. They were able to discharge the patients much earlier. We also seen reduction in ICU admissions postoperatively. So we didn't need to send these patients to ICU because they were doing so well intraoperatively. So they all save money for us. Here we have the representation of cost. Yellow sections are about the instruments and implants, and then blues are for the clinical care costs, and we sort of dropped on the clinical care cost about $3,000. And overall, we created a saving opportunity near $4 million with this project. And everybody got excited. And they said, we need to do this more. And the spine pilot program has become the norm for whole Harborview Medical Center surgical services. And we are trying to sort of distribute it to every surgical service line. And then with that, we have access to excellence dashboard, quality metrics. This is updated monthly. And everybody can see their HCAP scores, their 30-day all-cause readmissions, Foley removals. These are decided by our surgeons and physicians. They want to look at these metrics. So we're reporting them. We identify fallouts, and then we go back and address and find out why that fallouts occurred. So it's just ongoing QI process. It requires a team of people in a busy surgical environment with limited time for the surgeons to do. We provide them this support so they can learn from changes. And again, 4.2 days. This is our last quarter 2017 length of stay, 4.2 day. A ratio for ICU admissions, again, 1.7. So I will stop here. You might have some questions in SCOAP or for the program. I'm happy to answer. Thank you.